In our previous module, we documented the patient's journey up to the hospital doors. We now follow the patient into the clinical environment. Welcome to Module 2, Lesson 4, where our focus is Section 4, Emergency Trauma Care. This section is dedicated to documenting the in-hospital resuscitation phase, a period of critical activity and decision-making. Let us begin by outlining our learning objectives for this module. Upon completion of this session, you will be able to: first, identify the correct source documents for emergency department data, which include triage notes, physician and nursing charts, and laboratory and radiology information systems. Second, define the principles of data quality as they apply to the complex and time-sensitive ED environment. Third, you will be able to accurately enter all data within Section 4, from admission and triage through to interventions and the final disposition. Fourth, you will learn to correlate the various ED data points to the structure, process, and outcome components of the Donabedian model. And finally, you will be able to justify the need for meticulous accuracy in documenting ED care to support our quality improvement and research initiatives. Section 4 is the most detailed section of the MTR form. This module covers the entire patient journey within the emergency department ED, from the moment they arrive until they are either admitted, transferred, or discharged. This initial phase of in-hospital care, often termed the golden hour, is critical to patient outcomes. The data you enter here provides a detailed, time-stamped record of our hospital's immediate response to a trauma patient. We will proceed systematically through each component of this section to ensure you can document this complex phase with the required level of precision. We will systematically work through each part of this section: admission and triage, team response and patient history, clinical assessment, vitals and GCS, interventions and procedures, transfusions and investigations, final disposition. The data captured in this section is a direct reflection of our hospital's trauma response capabilities. It serves as the core dataset for our quality improvement programs and is critically important for three primary reasons. First, for measuring performance. Timestamps for arrival, investigations, and disposition are key performance indicators, or KPIs, that measure our efficiency and adherence to established standards of trauma care. This data is a direct measure of the process of care. Second, for resource management. Documenting the trauma team's composition, the procedures performed, and the blood products used helps us to understand and allocate our most critical resources effectively. This relates directly to the structure of care. And third, for benchmarking outcomes. By accurately recording the patient's condition upon arrival, their vital signs, GCS, and comorbidities, we can risk adjust our data. This allows for fair and meaningful comparisons of patient outcomes between different hospitals and is the very foundation of a successful clinical quality registry. Now let's walk through each field in Section 4. We will now begin our detailed exploration of Section 4, Emergency Trauma Care. The very first field, type of admission, is the starting point that defines the patient's entry into our hospital and their pathway through the trauma system. Your instruction for this field is to select the single option that best describes how the patient arrived at, and in some cases departed from, your specific hospital. The primary source documents for this information will be the emergency department's admission record, the ambulance's pre-hospital care or PHC form, or, in the case of a transfer, the official referral letter from the sending facility. Let us review each choice so the distinction is perfectly clear. You will select Direct for the majority of cases where the patient is brought straight from the scene of the incident to your hospital. You will select Yes Transferred In if the patient was first taken to another healthcare facility, be it a district hospital or a private clinic, and was subsequently sent to your hospital for a higher level of care. You will select Yes Transferred Out if your hospital was the first medical facility to treat the patient, and after initial stabilization, a decision was made to transfer them to another institution, for example, a specialized spine or neurosurgery center. Finally, the option Yes Transferred Both In and Out is for the more complex patient journey, where your hospital is the middle point. The patient arrived from one facility, received care from your team, and was then transferred onward to a third facility. The PEARL, or best practice for this field, is to understand that you are documenting a critical step in the patient's pathway. This data is essential for analyzing interfacility transfer times and auditing the efficiency of our regional trauma network. The most common pitfall to avoid is confusing a quote direct admission with a transferred IN admission. To be clear, if the patient was seen and assessed at any other healthcare facility before arriving at your doors, it must be documented as a transfer. By accurately capturing this first step, you provide the essential context for all the care and data that follows. For type of admission, if the patient comes directly to the reporting hospital, whether from pre-hospital care or as a walk-in, select Direct. The system will automatically calculate the time from the initial call to hospital arrival. Patient transferred into the reporting hospital refers to a patient who was transferred from another hospital or healthcare facility into the reporting hospital. Please select the correct referring healthcare facility from the list, provide the exact date and time of departure, and record the interfacility transfer time accurately. Transfer out of the reporting hospital refers to a patient transferred from the reporting hospital to another hospital or healthcare facility. Please select the correct receiving healthcare facility. Transferred in and out refers to a patient who is admitted to the reporting hospital from another hospital or healthcare facility, and then transferred back to the referring facility after completing care at the reporting hospital. Following the patient's admission type, we now document the critical communication step that occurs at the point of arrival. Field number 2, trauma handover. This field is not merely administrative. It is a direct measure of a critical patient safety process within the Donabedian Framework's process component. A structured handover ensures the seamless transfer of vital clinical information from the pre-hospital environment to our emergency department. Your instruction is to select the option that best describes this handover process. The source document for this information will typically be the ED admission notes, or the initial assessment written by the receiving nurse or physician, where they often document, quote, report received from ambulance crew. Let us clarify the meaning of each option. You will select yes if a formal, structured verbal report was provided by the pre-hospital team to the hospital team upon arrival. You will select no if the patient arrived by ambulance, but for some reason, no formal verbal report was given. You will select not available for patients, where a handover is not applicable, with the most common example being a, quote, walk-in patient who did not arrive via ambulance. And finally, you will select unknown if the clinical documentation does not mention whether a handover occurred or not. The pearl, or best practice, here is to understand that we are measuring a formal process. A structured handover, often using a mnemonic like ATMIST or ISBAR, is a key hospital procedure designed to prevent information loss. Your accurate entry is vital for auditing these communication protocols. The most common pitfall to avoid is assuming that any brief conversation constitutes a yes. You should only select yes if the notes indicate a formal, structured report was given. If the patient was simply brought into the resuscitation bay with no documented verbal report, no is the correct and more accurate choice. By accurately documenting this step, you provide essential data for evaluating our communication protocols and improving patient safety at one of the most vulnerable points in the patient's journey. Continuing with the patient's arrival process, we now come to a set of fields that are fundamental to understanding how we assess and prioritize patients in the emergency department. Fields 3, 4, and 5, which cover triage and under-triage. First, for field number 3, initial ED triage, you will record the triage category that was assigned to the patient immediately upon their arrival at the emergency department. This is the very first assessment of their acuity. The source for this will be the official ED triage form, or the initial nursing notes. Next, for field number 4, final ED triage, you will record the patient's last documented triage category before they were disposed from the ED, that is, before they were admitted to a ward, sent to the operating theater, or transferred out. This leads us to field number 5, under triage. This is a critical quality metric. Your instruction here is to check if the auto-populate is correct. Yes, if the patient's triage category was upgraded at any point during their ED stay from green to red. Let's clarify the choices. The triage categories, rhesus, red, semi-critical yellow, and non-critical green, represent a standardized assessment of urgency. Rhesus is for life-threatening conditions, yellow for potentially serious conditions, and green for non-critical issues. The final triage may be the same as the initial, or it may be different, reflecting a change in the patient's stability. Under triage, therefore, is a calculation. If the final triage category is more severe than the initial, then under triage is yes. The pearl, or best practice here, is to recognize that under triage is a vital patient safety and quality improvement metric. By accurately capturing when a patient's condition is more severe than initially assessed, you are providing the essential data needed to audit and improve our front door triage processes. The most common pitfall to avoid is confusing the initial and final triage. A trauma patient's condition can change rapidly. You must record both the first assessment and the last assessment to accurately reflect their clinical journey within the ED. Simply entering the same value for both without checking the records is a missed opportunity to capture important clinical data. Continuing with the patient's arrival, we now move to field number 6, trauma resuscitation facility used. This field is designed to capture a critical aspect of our hospital's structural readiness for trauma care. Your instruction here is to select the option that best describes the physical location and the resources where the patient's initial resuscitation took place. The source document for this information will be the emergency department's physician or nursing notes, or the resuscitation flowchart, which often documents the location of care. Let's take a moment to precisely define each option. as the distinction is important. You will select dedicated trauma bay if your hospital has a resuscitation bay that is physically designated and equipped exclusively for trauma patients, but staff are shared with general resus. You will select shared resuscitation bay if the patient was resuscitated in a bay within the general resuscitation zone, or red zone, which is used for all types of critical patients, including trauma, cardiac arrests, and other medical emergencies. This is a common setup. The highest level is dedicated trauma service, which indicates not just a dedicated space, but also a dedicated staff, specialized trauma team, that was activated to manage the patient upon their arrival. Finally, not available or unknown should be used if this information is not documented. The PEARL, or best practice for this field, is to understand that you are measuring the structure component of the Dohnavedian model. This data is vital because it helps us correlate specific hospital resources, like a dedicated trauma bay, with patient outcomes. This is a core function of a clinical quality registry. The most common pitfall to avoid is confusing a dedicated trauma bay with a shared resuscitation bay. A dedicated bay is reserved only for trauma, which is a significant structural resource. A shared bay is the standard for most emergency departments. Making the correct distinction here is essential for the integrity of our data. By accurately capturing this, you are providing a clear picture of the structural resources that were available to the patient at the moment of their arrival. We will now discuss two fields that are intrinsically linked and provide a clear picture of our hospital's organized response to a major trauma, Fields 7 and 8, which cover trauma activation and composition. First, for field number 7, activation of the trauma team, your instruction is to indicate if a formal activation occurred. If you select yes, a new drop-down menu will appear, and you must then select the highest level of experience provider from the ED who is leading the resuscitation. The options range from consultant, our most senior specialist, down to the senior medical assistant or staff nurse. Next, for field number 8, trauma team members composition. Your task is to check all the boxes for the different medical specialties that were documented as being present during that initial resuscitation. This is a multi-select field, so if emergency medicine, surgery, and orthopedics were all present, you must check all 3 boxes. The source for this information will be the official ED resuscitation record, or the physician's notes. The PEARL, or best practice, here is to understand how these two fields work together to tell a story. Field 7 measures the process of care. Did we follow our protocol and formally activate the team? Field 8 then measures the structure of care. What actual human resources and specialties were brought to the patient's bedside? The most critical pitfall to avoid is confusing a formal trauma team activation with an informal consultation, where various doctors happen to see the patient. You should only select yes for activation if a hospital-wide protocol was initiated, often via a pre-alert from an ambulance, to assemble a multidisciplinary team specifically for that patient's arrival. If doctors were called ad hoc after the patient had already been assessed, the correct answer is no. By accurately documenting both the activation and the composition, you provide invaluable data for us to audit the effectiveness and efficiency of our trauma response system. We will now discuss two fields that are crucial for understanding the context of the patient's overall health. Fields 9 and 10, which document the patient's comorbidities. These fields are designed to capture the patient's baseline health status before the traumatic event occurred. This is a critical concept known as risk adjustment. It is not a fair comparison to expect the same outcome for a healthy 20-year-old and an 80-year-old with multiple medical problems, even if they have the exact same injury. This is the data that allows us to make those fair comparisons. First, for field number 9, the pre-injury ASAPS classification system, your instruction is to select the single number, from 1 to 6, that best represents the patient's general health before the injury. As you can see on the slide, ASA1 represents a normal, healthy patient, while the score increases with the severity of pre-existing disease, up to ASA5 for a moribund patient. Next, for field number 10, the Charlson Comorbidity Index, you will see a multi-select checklist. Here, your task is to check all the specific pre-existing medical conditions, such as prior myocardial infarction or diabetes, that are documented in the patient's record. The source document for both of these fields will be the patient's past medical history, which is typically found in the emergency department physician's notes or the hospital's admission records. The PEARL, or best practice, here is to understand that this data is the foundation of risk adjustment. It is what allows the registry to make fair and scientifically valid comparisons of outcomes between different patients and different hospitals. The most critical pitfall to avoid is allowing the patient's current condition from the trauma to influence your selection. You must only consider their health status before the injury. For example, a patient who is now moribund and would be classified as ASA5 because of their severe injuries might have been a completely healthy ASA1 just hours before the event. It is their pre-injury status that you must capture. By accurately documenting this baseline health, you ensure the integrity of our registry's quality analysis. We will now address two of the most clinically significant fields related to a patient's pre-injury health, fields 11 and 12, which document anticoagulant and antiplatelet use. Your instruction for these fields is to select yes or no to indicate if the patient was taking these types of blood-thinning medications before their traumatic injury. The source document for this critical information will be the patient's official medication history, their medication chart, or the initial assessment notes from the ED physician or nurse. If you select yes for Field 11 anticoagulation use, you must then specify the type of anticoagulant. Anticoagulant types include vitamin K antagonist warfarin, direct oral anticoagulants, DOAC, apixaban, rivaroxaban, dabigatran, low molecular weight heparin, enoxaparin clexane, unfractionated heparin, standard heparin infusion, and also document if a reversal agent, like fresh blood products, was administered in the emergency department. The pearl, or best practice here, is to understand that this information is one of the most important risk factors in any trauma patient. A yes in either of these fields immediately signals to a clinician or researcher that this patient had a significantly higher risk of severe uncontrolled bleeding. Therefore, your accuracy is paramount. The most common and critical pitfall to avoid is failing to check the patient's full, documented medication list. A patient, especially an older one, may not remember or think to mention that they take a daily low-dose aspirin, which is an antiplatelet. You must rely on the documented medication record from their chart, not just the history they provide. By accurately capturing this information, you are providing essential data that directly impacts the risk adjustment models we use to analyze patient outcomes. This ensures that our quality reviews are fair, accurate, and clinically meaningful. We will now proceed to one of the most clinically significant parts of this section, fields 13 through 18, which document the patient's clinical assessment on arrival. This data provides a precise, time-stamped snapshot of the patient's physiological state the moment they enter our care. Your instruction here is to enter the first complete set of vital signs that were recorded after the patient's arrival in your emergency department. This includes the pulse rate, systolic and diastolic blood pressure, respiratory rate, and the first recorded oxygen saturation. Please note that Field 15, the shock index, is automatically calculated by the system based on the pulse and systolic blood pressure you enter. You do not need to input this value yourself. For Field 18, the Glasgow Coma Scale or GCS, you will use the interactive sliders to input the individual scores for the eye, verbal, and motor responses. The total GCS score will then be automatically calculated and displayed. The source document for all this information will be the ED triage form, the ED observation chart, or the initial assessment notes from the attending nurse or physician. The pearl, or best practice for this section, is of paramount importance. The GCS score that you record here must be the pre-intubation score. This score is a fundamental baseline of the patient's neurological status and is a critical variable used by the system to calculate the Trauma Injury Severity Score, or TRIS, which predicts patient survival. A post-intubation GCS is not a valid measure for this purpose. The most common and critical pitfall to avoid is entering vital signs from the ambulance's PHC form in this section. I must reiterate, these fields are exclusively for the first set of vitals taken at the hospital. The pre-hospital data belongs in Section 3. By accurately capturing this initial in-hospital assessment, you are providing the essential baseline that allows us to fairly and accurately measure the impact and outcome of the care we provide. We will now review one of the most important parts of Section 4, the fields documenting the core life-saving interventions performed in the emergency department. These are fields 20 through 24. As you can see, these fields are organized according to a globally recognized clinical standard, the Primary Trauma Survey, or ABCDE. Your instruction for this entire block is to treat them as multi-select checklists. You must carefully review the ED physician and nursing notes, or the resuscitation record, and check every single box that applies to an intervention performed in the ED. Let's walk through the clinical correlation, which is the pearl, or best practice, for this section. Field 20, Airway Management, corresponds to A for airway. Field 21, Breathing/ventilation management, corresponds to B for breathing. Field 22, Circulation/hemorrhage control management, corresponds to C for circulation. Field 23, Immobilization management, corresponds to D for disability, where we protect the spine. And Field 24, Exposure, corresponds to E for exposure, where we manage the patient's temperature. Thinking of these fields as the A, Core B for TECTA C, Core by E framework will help you ensure you are capturing the complete story of the patient's resuscitation. The most critical pitfall to avoid here is data contradiction. For example, if you check chest tube insertion under breathing management, you cannot also check no intervention needed. These options are mutually exclusive. Similarly, a patient often receives multiple circulation interventions. If a pelvic binder was placed, large bore IV catheters were inserted, and tranexamic acid was given, you must check all three boxes to accurately reflect the intensity of the resuscitation. By accurately and completely documenting these interventions, you are providing a precise record of the life-saving processes of care delivered in our emergency department. We will now discuss the final intervention field in this section, field number 25, Advanced Resuscitation Interventions. This field is dedicated to capturing a specific subset of highly specialized and often life-saving procedures that may be performed in the emergency department for the most critically injured patients. As with the previous intervention fields, your instruction is to treat this as a multi-select checklist. You must review the ED physician's procedure notes or the resuscitation record, and check all the boxes that apply. Let's briefly review some of the procedures listed here so their significance is clear. ED resuscitative thoracotomy. This is an emergency procedure to open the chest in the ED, typically for a patient who has just lost signs of life. Cranial burr hole. This involves drilling a hole in the skull to relieve pressure on the brain. REBOA, resuscitative endovascular balloon occlusion of the aorta. This is a highly advanced technique to control massive internal bleeding by placing a balloon in the aorta. The pearl, or best practice, for this section is to recognize that the procedures on this list represent the highest level of trauma care capability. Accurately capturing when these interventions are performed is essential for the registry to understand the resources required to manage the most complex and critically injured patients. This data is vital for system planning and resource allocation. The most common pitfall to avoid is confusing a standard procedure with an advanced one. For example, you should not check deep wound packing for the application of a simple wound dressing. This field is specifically for instances of significant, deep packing performed as a major hemorrhage control measure in a large wound cavity. When in doubt, always refer to the MTR data dictionary or consult a clinical team member to ensure the procedure meets the definition for this field. By accurately documenting these advanced interventions, you are providing a clear picture of the highest level of care our trauma system can provide. We will now cover the critical diagnostic phase of emergency care, fields 26 through 31, which document the imaging performed in the ED. Your instruction for this section is to document all imaging that was performed within the first 24 hours of the patient's arrival. For each modality, that is, X-ray, ultrasound, USS, CT scan, and MRI, you will see a multi-select checklist. You must check all the boxes that apply. For example, a patient may have had a chest X-ray, a pelvic X-ray, and an EFAST ultrasound. You must check all three. The most important part of this section relates to the CT scanner. For field 29, you must enter the exact time and date that the first initial CT scan was performed. From this, the system will automatically calculate field 30, the quote, time from arrival to first initial CT. The source for all this information will be your hospital's Radiology Information System, RIS, or the official radiologist report, which will have precise timestamps for when the images were acquired. The pearl, or best practice here, is to understand the immense importance of the quote, time from arrival to first initial CT. This is a major international key performance indicator, or KPI, for trauma care. It is a direct measure of our hospital's efficiency in diagnosing life-threatening injuries. Your accuracy in entering the patient's arrival time earlier in Section 4 and the CT scan time here is absolutely critical for this metric to be valid. The most common and significant pitfall to avoid is entering the time the CT scan was requested by the doctor instead of the time the scan was actually performed. The KPI is designed to measure the time to diagnosis, so the correct time to use is the time the first image was acquired by the scanner, which will be documented in the radiology system. By accurately capturing this imaging data, especially the CT scan timestamps, you are providing essential data that allows us to benchmark our diagnostic performance against national and international standards. We will now cover a critical aspect of hemorrhage control and trauma, fields 32 through 34, which document blood transfusion. Your first instruction is for field 32, blood transfusion required in ED. If you select yes, a detailed set of fields will become active. It is mandatory that you then select the transfusion protocol that was activated, with the most common for severe trauma being the massive transfusion protocol. Following this, you must enter the exact number of units, meaning the number of bags, and the total volume, in milliliters for each blood product that was given in the emergency department. This includes packed cells, fresh frozen plasma, FFP, platelets, and cryoprecipitate. Note that the quote blood product ratio will be automatically calculated by the system based on the units you enter. Finally, you must document any adverse events in fields 33 and 34 by checking all applicable boxes for transfusion errors or transfusion reactions. The source for all of this information will be the official blood bank transfusion slips or records, as well as the patient's medication chart and clinical notes. The pearl, or best practice here, is to understand the significance of the blood product ratio. This ratio, typically aiming for 1:1:1 of packed cells, FFP, and platelets, is a critical international benchmark for best practices in hemorrhage control. Your accuracy in entering the correct number of units for each product is absolutely essential for the system to calculate this ratio correctly and allow us to audit our performance. The most common and critical pitfall to avoid is confusing units and volume. Units refers to the number of bags transfused, for example 5 units of packed cells. Volume refers to the total milliliters contained in those bags. Both fields are mandatory for each product, and both must be entered correctly from the official transfusion record to ensure our data is accurate and complete. We will now proceed to the final part of the clinical assessment in the emergency department, fields 35 through 46, which document the key blood investigations. This data provides a biochemical picture of the patient's physiological state and their response to our initial treatment. Your instruction for this section is to document 2 specific points in time for several key lab tests. The initial value, which is from the first blood sample taken upon the patient's arrival in the ED, and the last value, which is from the final blood sample taken just before the patient was disposed from the ED. For each of these values, you must also enter the corresponding date and time the blood was drawn. The source for this information will be your hospital's Laboratory Information System, or LIS, or the patient's integrated electronic medical record where lab results are displayed. The pearl or best practice here is to understand the clinical significance of this data. The initial base excess and initial lactate are critical biochemical markers that tell us the severity of shock the patient is in. The difference between the initial value and the last value is a direct, objective measure of how well the patient has responded to our resuscitation efforts. Your accuracy in capturing these 2 data points and their times is absolutely vital for clinical auditing and for understanding the effectiveness of our care. The most critical pitfall to avoid is mixing up the initial and last values. It is a common error to enter a later value in the initial field. The initial value must be from the very first blood sample drawn in the ED, and the last value must be from the final sample before disposition. Entering these in the wrong fields will completely invalidate any analysis of the resuscitation's effectiveness. By being meticulous here, you ensure that our measurement of this critical process of care is accurate and meaningful. We have now reached the final set of fields in Section 4, which document the conclusion of the patient's journey within the emergency department, fields 47 through 49, covering ED disposition. Your first instruction for field 47 is to enter the exact ED disposition date and time. This is the precise moment the patient physically left the emergency department to go to their next destination. Next, for field 48, you will select that immediate ED disposition destination from the comprehensive list of choices. Explanation of choices. Ward ICU, direct admission to an inpatient bed. OR/angio then. The patient's first stop after the ED was the operating room or interventional radiology suite. Death in ED. The patient was pronounced dead within the emergency department. Transfer out. The patient was stabilized and transferred to another healthcare facility. If this is selected, you must specify the reason and the receiving hospital type. DAMA, discharged against medical advice. Finally, field 49, the ED length of stay, is a value that you do not need to enter. It will be automatically calculated by the system based on the arrival time you entered earlier and the disposition time you just entered. The source for this information will be the ED's clerical records, the patient tracking system, or the final time-stamped entry in the clinical notes. The pearl, or best practice, here is to recognize that the ED length of stay is a major key performance indicator, or KPI, for measuring hospital efficiency and patient flow. Your accuracy in entering both the arrival time and the final disposition time is absolutely essential for this metric to be valid and meaningful. The most critical pitfall to avoid is selecting the patient's final hospital destination instead of their immediate destination from the ED. Let me give you an example. If a patient is taken from the ED to the operating room for surgery and then admitted to the ICU, the correct choice here is OR/angio, then ICU. Selecting just ICU would be incorrect, as it misses a critical step in the patient's pathway. By accurately documenting these final steps, you are providing a clear and complete record of the patient's entire journey through the emergency department, which is essential for our quality and performance analysis. Let us now summarize the key takeaways from this extensive module. First, Section 4 documents the core process of in-hospital trauma care, which is supported by the structure of the responding team. Second, accurate timestamps are non-negotiable for measuring performance. Third, the source documents are varied. You will need to synthesize information from triage forms, clinical notes, and lab and radiology systems. And finally, the patient's condition on arrival provides the critical baseline for everything that follows, allowing for fair and accurate outcome analysis. This concludes the training for Section 4, Emergency Trauma Care. You now understand how to document the complex and time-sensitive care delivered in the emergency department. The data you enter here is the very backbone of our trauma quality improvement program. By being meticulous and accurate, you are providing the essential data that helps us analyze our performance, save lives, and improve the standard of trauma care for all Malaysians. In our next module, we will follow the patient beyond the ED as we cover Section 5, Further Management. Thank you.